welcome back. It is another episode of Grow RDH podcast. My name is Katie. I'm your host. I'm a dental hygienist from South Dakota. And today we're going to be switching gears a little bit. If you are new to the podcast, welcome. We talk about all things dental hygiene related, some serious, some clinical, some just kind of random talking stuff. And today we're going to switch gears in that we've been talking a lot about ethics and CEs and just kind of some really more basic things. I want to switch gears into perio, and my background, a little bit of background on me is I've been teaching perio at a university since about 2015. And it's just a topic that I really am passionate about. It's something that I love talking about. I think it's just our niche, right? That is what sets us apart as a dental health professional. And I think that a lot of some of the questions I get or some of the things that we talk about in class really help to sort of steer hygienists in the right direction in terms of classifications and just some common questions about staging and grading. And I think that it's just a great topic. It's my favorite topic. And if you are listening to this in April of 2024, I do have a perio workshop coming up in July 13th. So if you're interested in joining in the workshop, we are going to be live on Google Meet, and you can sign up for that at my website, growrdh.org. The workshops that I try to put on are really workshop related, right? It's not a typical CE where we just sit around and I talk to you for an hour. It's nothing like that. Workshops are very engaging. There's going to be 2 case studies that we stage and grade together. We're going to be talking about CAL. And I just really want it to be interactive. So if you have any questions about the workshop, please feel free to reach out to me. But you can find that again at growrdh.org. So today we're going to be, like I said, changing gears. We are going to be talking about staging and grading and why it's amazing. The title of this episode is going to be Staging and Grading is Amazing. Here's why. And again, I love this topic. This is a passion of mine, and I'm excited to talk about it today because I think there's a lot of questions. There's a lot of gray area or seemingly gray area that maybe isn't so gray when we really get down to the nuts and bolts of how we classify patients. So just a little bit of background on this topic. I graduated in 2009. So when I graduated, we learned the 1999 classification system. This was a PDC, periodontal disease classification system. We called it PDC. And PDCs were, again, great. They were a way to classify. That's how I learned it. That's probably how many of you learned it. And PDCs were just based on severity of gingival disease, starting at 0, which was healthy, and 4, which was severe disease. And so what we're going to talk about is how that changed and why. And so we are going to go all the way back in time to 2017 when the American Academy of Periodontology and the European Federation of Periodontology met and got together, and they called it the World Workshop. What they did was they completely revamped the diagnosis and classification system of periodontal diseases. I think that this change was sort of met with a lot of concern, a lot of hesitation, because I just think change is hard, right? Change is hard, especially for those hygienists and dentists that have been using PDC successfully for years. And, change is hard. That's how we learned it. It's hard to learn, completely change your mindset on these bigger types of things. And so we're going to discuss today 3 improvements. 3 reasons why this change is amazing. This change is the bee's knees. It's awesome. It gives us so much more to work with when we're trying to guide patients towards better periodontal outcomes, really. And that's what we're supposed to be doing, right? We are supposed to be guiding patients towards better health outcomes. And specifically for us, that is the majority of what we do. Majority of us are treating, preventing, and maintaining periodontal diseases. And so this is should be a really important topic to us and something sort of near and dear to our hearts. Um, the background of this is in 2017, when they introduced this, they wanted it to be very similar to medical diagnostic techniques. And if you go onto the American Academy of Periodontology website, they have all of the findings of the World Workshop for free. They're open access. So any office, any hygienist can go to their website and access all of the findings, all of the articles, anything that I'm going to reference today. That is on their website. So please, if you have not dove into that, maybe you've just taken a couple classes, you've integrated it into your offices, but you haven't really read it. There is a ton of published research on why they made these changes and why these changes are important, what it means to us. They go into very great detail, though. And so the article that I'm going to reference in this podcast episode and the article that I will link in the description box below is probably where you should start. It is a great summary article in which it covers the majority, like the bulk of it, right? It's a really good summary. It's like taking a lit review and kind of summarizing it down into main points, what they found, and why it's important. What I want to do today, just to start this topic, right? This is a huge topic. Staging and grading, periodontal disease classifications in general is a huge topic. So what I want to do today is really just talk about why it's important to implement. There are three really big improvements, and I want to talk sort of in order about what I think the best improvements were. I'm interested to hear from you guys about what your experience with integrating this was. I would love to hear from you what you think that the best improvements were or why you think it's a good thing. So if you have comments, questions, I will repeat this again at the end, but any comments or questions about staging and grading, you can direct to katie@growrdh.org. That is my email address. Please send any stories, anything, any questions, any experiences or stories that you would like to share to be read on the podcast for others to hear. I completely welcome that. I would love to incorporate more listener stories into future episodes. So please reach out if you have questions or comments. With that, we are going to get into the first improvement. The first, and probably my favorite, and I talk about this in class with the students a ton, my absolute favorite improvement on the staging and grading system is that they blew health categories, blew them wide open. They gave us so much more detail and criteria that we can use to help categorize health. That was huge. Not only is there health, we know that very few patients fall into health on a stable periodontium. We know that there are very, very few patients that fall into that category. Many of us have periodontal damage due to some reason. I'm a perfect example. I have a lot of recession on my lower premolars because I had ortho as an adult. I think I got my braces on 23 or 24. It was my first big purchase after I was done with school and had an actual real job that I felt very financially stable. And that was one of my biggest purchases was I got ortho as an adult. And with that, I did end up with some recession, mainly around my premolars. But yeah, I would definitely fall into that category where I have I have loss. But I don't fall into the health category, and I didn't really fall into the category of any of the PDCs because there wasn't that category of health on a reduced periodontium. What the 2017 findings have done is they've now given us three different categories of health. The first is health on a stable periodontium. Again, we talked about that. Very few patients fall into that category. The second category of health is health on a reduced periodontium for any condition, any reduction that's not related to periodontitis. So I would fall into that category. I have recession, and so I do not have a stable periodontium, but my tissues are healthy. And so I would fall into the category of health on a reduced periodontium, not related to perio. The third category is health on a reduced periodontium in stable perio. That is also huge. We sort of had this gap where we had patients in remission, periodontal maintenance continually, and they're stable, they're healthy, and they're in remission from periodontitis, but we still sort of staged and graded them. I'm sorry. We still categorized them as they had active disease, and they didn't. And so this was a huge improvement. What I think this has done clinically, in my experience, again, I'm in South Dakota. I work at a school, and I have subbed around in some private practices around my area, and I also work at a corrections facility. What I have seen, and in my experience, this has greatly reduced the instances of misdiagnosing or overdiagnosing periodontitis in patients that have CAL, but the damage wasn't attributed to the disease. I've seen this many times. It is a huge improvement. Many of our patients, like I said, do not have intact periodontiums. And so this opens up a whole new category where we have the verbiage, we have the terms that we can use to really be descriptive about describing the patient's health and talking about that on a more accurate scale. Having a diagnosis category that clearly outlines those scenarios really improves the options that we as clinicians have when describing the state of the mouth. Improvement number 2. This has really helped as well. Again, the health categories were my favorite improvement. I have this as number 2 because I think this is the biggest change. Do I think that health was maybe not quite as big a change? Yes, but it's my favorite change because of my personal situation. But I do think that improvement number 2 is probably the biggest change. And this involves increasing the criteria that help us describe case progression. So prior to 2017, as you know, the 1999 classification system categorized the differences in speed or progression by simply using age and bone loss. Really, if we look back at looking at the ratio, and again, I've worked in corrections facilities. A lot of younger patients really had just traditional chronic periodontitis because they've never had a cleaning before. And based on their age, a lot of them fell into that aggressive diagnosis. And really, the progression of the disease wasn't fast. It wasn't a risky case. It was just the very large amount of biofilm and calculus that was present was really to be expected with how much inflammation and destruction that they had. And so what we did then in 2017 was we completely got rid of the terms chronic and aggressive. Those are no longer terms that we use to categorize or diagnose. The workshop highlighted the limitations of that technique, really. They said one of the biggest complaints at the workshop was there's no clear criteria to distinguish the differences between chronic and aggressive. Age is not a good way to sort of determine the difference of that. And there's really no other way there in those existing terms back then. And so what they identified was that the differences of progression rates were way more nuanced than just age. And I know that we've experienced that. I know that a lot of us have seen this clinically. And so now what they've done is they've made the grading process. The grading process is a way for us to much more objectively define how their specific individual disease is progressing. It's way more nuanced. And again, this is the second improvement. This is probably the biggest improvement, but this is the second one because it is so important. That grading system, which I foresee, I'm sort of projecting here, kind of making a guess, an educated guess. I foresee the grading system to change. I foresee that to be improved because as we've been teaching it and implementing it, we can see that there are things pretty big things that are missing from that. And one of those things was vaping. We talk in school when we teach it about the smoking, and a lot of cases where they are using tobacco, but there's no really, not, excuse me, not tobacco. They are using vapes and other forms of nicotine, and there's no way to quantify that really. And so, what I foresee is that as more research comes out, there'll be better ways to quantify those individual things. Same thing with obesity. We know that obesity has, I think it's the number two right now. It's the number two lifestyle factor or risk factor in perio. And what I foresee is that maybe there are some quantifying factors about how obesity may impact the progression or maybe change the grade. Those are just some guesses, educated guesses. If I had to project into the future to see what I see changing, that's what I would see, is more categories or more objective, measurable things that we can use to change our grade. So the criteria right now in our little box, again, you can get these sheets, the decision trees on AAP. I also have a decision tree that comes in a PDF. You get my PDF, the one that I made, I give to the students signing up for the workshop. So if you come to the workshop in July, you're going to get a really cute, fancy decision tree with all of this information. But what it includes now is phenotype, smoking status, and diabetic status. And those three things in the findings of the 2017 World Workshop were the three biggest factors that helped dentists determine the rate of progression. And so smoking status, pretty easy. Same thing with diabetic status. Those are just numbers. The phenotype is where some students and maybe some clinicians get a little bit fuzzy. And in some of the literature, they call it biotype. But phenotype is really just how the case presents in terms of how the body is responding to the bacteria. And this is really important. And this can be a really good indicating factor for us to further investigate if that patient has something else going on. Specifically, if you have a fast phenotype, that's where we might see a lot of aggressive cases back in the day. That's what we would call aggressive. But a fast phenotype means that their body is responding in a very unnatural or not as expected way. Their body is responding higher than what is to be expected. And a lot of clinicians, the easiest way to kind of see this is what percentage of biofilm compared to what percentage of inflammation in the whole mouth. So if you have a really low, light plaque and calc patient, they have very little buildup, and you're seeing a very exaggerated inflammatory response in the gums, that there's just bleeding all over, and it seems to be that the inflammatory response is exacerbated by something. That should sort of give you a little bit of a red flag. We need to further investigate. We need to maybe go deeper into the health history. Maybe there's something systemic going on that is creating this inflammatory response. It's creating a situation in the mouth where the body's host response, the body's reaction to that plaque, that very little plaque, is way over exaggerated. And that's sort of how we define phenotype. That's how we look at phenotype to kind of lead us into further questions about what could be happening. How could this expression of inflammation be tied or linked to something else? And that's my favorite part of phenotype. That's my favorite part of the grading system, is it helps clinicians and students. It helps us sort of do a little bit of critical thinking, like, this doesn't match, and something else is going on. Next, I'm going to talk about improvement number 3. Improvement number 3 is sort of highlighted in this summary article. I put it last because while I do think it's important, I don't think it's quite as big as an important as 1 and 2. So improvement number 3 is using the language of staging. Staging is used in the medical world for diagnostic categories and is very recognized when discussing disease status. This is an improvement identified by the AAP because they were able to discuss periodontal disease categories in a way that's familiar. Now, not only is this familiar to medical professionals, right? A lot of staging terms are used in oncology in terms of diagnosing cancer. And so it's familiar to health professionals. When they hear the term staging, they think, you know, to what extent is the disease present? And it's very familiar. So we can communicate with other oral health or not oral, any health professionals and use the term staging, and they're like, "Oh, yeah, we get what context that's used in." But not only do health professionals understand this, patients also understand it. And that was referenced again in this article. It is easier to talk to patients about staging because they've heard that term before. Very likely that they've had a friend or family member that has had some sort of cancer, maybe. And that term staging puts it into context of like they have something to compare it to. They know that staging means, how bad is it really? And not only that, but I think it helps patients understand the seriousness. Now, I'm not equating periodontitis or any periodontal diseases to cancer, not equating them. What I am doing is that it helps them understand this is a chronic disease in the terms that this is something that is it's an infection. It's something that is happening in their mouth that's not just, they so much associate bleeding gums, gingivitis. They don't maybe necessarily all the time understand that this is a serious disease and you have to take it seriously when it comes to treating it, because it's not something that's just going to go away in the blink of an eye. It's comprehensive, it's life changing really, because a lot of people will be dealing with this disease for the life of their dentition. They're going to be maintaining and dealing and maintaining it. I've said that a couple times. Sorry for being repetitive. I just don't have a better word to describe how comprehensive and life-changing a periodontitis diagnosis can be or can seem. And what was referenced in the article and what I've seen personally is that when you're using that staging terminology, it really does help click on that light bulb for patients to understand, wow, this is a serious disease. Patients, I think they're more likely to take it serious. This is an inflammatory response, very similar to those that might be going on systemically, that impact overall health. And that is it for today. So just to summarize, improvement number 1, we have a ton of different health categories now compared to 1999. Improvement number 2, we have gotten rid of the terms chronic and aggressive and replaced them with more an objective measurement of grading. And 3, using the language of staging is much more identifiable and relatable to oral health professionals, medical professionals, and patients themselves. So that is the end of this podcast. I hope you like it. I am going to sort of continue this shift into talking about more periodontal related things. And I think what we're going to be doing next week is talking about Cal and specifically where that gray area can lie between maybe a gingivitis pseudopocket patient and a stage 1 4mm true pocket situation. And so I think there's a lot of gray area there. There's a lot of sort of debate and sometimes controversy depending on who you're kind of getting into the weeds with. But I think there's a lot of concern about overdiagnosing. There's concern about underdiagnosing. And so what I want to talk about next week is really defining Cal, how we feel Cal, and how that really, there's not much gray area in those two differences. There's a very specific thing that helps us determine this is a pseudopocket, this is a stage 1 4mm loss. And so we're going to be talking about that next week. If you have comments, questions, stories that you would be willing to share with me or that you would like answered, please email me at katie@growrdh.org, and I would be happy to read your question on the podcast. I would happy to be just answer you privately if that's what you prefer. Please specify if I can read it on the podcast, of course. But we will be back next week with that topic, and I hope you look forward to a lot more. Enjoy spending time with you, and I appreciate you spending time with me listening to the podcast. If you want to, and if this is valuable to you, please consider liking on YouTube. I'm on YouTube. I'm also on Spotify. If you listen on Spotify, subscribe to the podcast, and you can sign up for the newsletter. Every podcast episode goes out to my newsletter recipients, and so that way you will not miss an episode. I will link the article that I've been referencing down in the description. So if you want to read that article, I highly suggest you go on to the AAP website or just click on the link that I'm going to share with you. And I hope you guys have a great weekend. This will come out on Friday. So if you're listening a little bit later, have a good week. And I hope to see you back next time. Thanks.